You searched and NEI's experts answered. Here, NEI faculty answer the web's most searched questions on mental health concerns. I'm Dr. Andy Cutler, Chief Medical Officer of Neuroscience Education Institute, and with me here today is my good friend, Dr. Manpreet Singh. Manpreet, how are you?
I'm great, Andy. I'm ready to do this. How about you?
Me too.
All right. Shall we get started with the first one?
Yes.
Can bipolar disorder run in the family? That's our first autocomplete.
I love that question because most of our mental illnesses do have a genetic association, and bipolar disorder has one of the highest genetic linkages. So we know that there is a very strong association of a family history of mental illness of many kinds, including any mood disorder, bipolar or major depression, also substance abuse, substance use disorders. Manpreet, I know you know a lot about this. What would you say?
Yeah, absolutely. Bipolar disorder can run in families and is among the most frequently to transmit across generations. One of the things I would say, though, is people wonder this, and the glass isn't just half full or half empty. You're not doomed to be following in the footsteps of your parents or generations ahead of you. Right. It's quite possible that you might be totally resilient from developing bipolar disorder, even if you have a family member who has the disorder. Mm-hmm. It's quite possible that you develop the same kind of condition, in which case it could be very helpful to know how the treatment went and how the history was for other family members. It's quite possible that you have some other condition other than bipolar disorder, because those kinds of symptoms, mood symptoms more generally, tend to cluster more frequently in families affected by bipolar disorder. So it's not just a one-to-one deal, and we unfortunately can't look into a crystal ball and make a definitive diagnosis just based on family history. How I think about it when I interact with patients and families is just that. It's not a crystal ball. There are many ways that people can live with the condition and do just fine. Right. We want to understand what factors put you at risk, what factors keep you resilient, and how we can optimize your functioning over the course of the lifespan. And you might never see the light of day of any bipolar symptoms because of a family history. But it is important for healthcare professionals to know about that family history, because it could potentially, a manic episode could potentially come on at any point in your life. Yeah,
but Manpreet, there are so many newer effective treatments too for bipolar, so you're right that you're not doomed to follow in the exact footsteps. Right. And very often in previous generations, people weren't accurately diagnosed and certainly not well treated. So the good news is that there are a lot of newer treatments that are available. And I want to say, as somebody who's done a lot of clinical trials and research, family history is one of the best clues and one of the best diagnostic tools to help us diagnose bipolar accurately, because the most common misdiagnosis is unipolar, we call it major depression or major depressive disorder, MDD. And a depressive episode can look the same or very similar whether it is unipolar MDD or bipolar disorder, which of course features mood cycles up into the hypomanic and manic range, and the treatments are very different. So it is very important, if there is a family history or if you are having symptoms, to get it evaluated, because help is available.
Yeah, you're raising a really important point. It's subtle, it's nuanced, and it requires more than just a quick autocomplete on Google, right? To be able to sort it out. So a healthcare professional can help integrate the multiple factors and risk factors that contribute to risk for developing a manic episode, to interpret a depressive episode while understanding what else might be coming, how to help you look for clues or look for potential symptoms. And
Speaking of that, some of the things that I ask are, anybody in your family have a nervous breakdown? And a lot of times that can be a clue to a manic or hypomanic or even a severe depressive episode. Family history of suicide, family history of somebody who's been hospitalized or institutionalized. And then one that a patient actually taught me. If we're smart enough, we listen to our patients.
Yeah, absolutely.
A patient once said, "They tell me I'm like my crazy Uncle Harry. Do you think that's important?" And I went, oh my gosh. When I asked about his Uncle Harry, sounded bipolar, and it really was a clue to making the right diagnosis.
Right. And we have to make, cautious interpretations about how people talk about their family members. Sometimes it feels really hard to talk about Uncle Harry in the most honest way.
Yeah.
And we use words that may or may not actually reflect that person. I try to remind myself and my family and families and patients that I work with that, you aren't bipolar, you have bipolar disorder. It's an important difference.
Nice.
And it helps destigmatize the condition and get the treatment that you need in a timely fashion. All right, let's go with the next one.
Let's do it.
Can bipolar disorder get worse with age?
Oh, the answer is clearly yes, especially if not adequately treated. I like to say sometimes bipolar disorder is like a rock rolling downhill. It kind of rolls faster, so mood episodes can cycle faster or accelerate. They can sometimes get worse. And unfortunately, we're even starting to recognize there may be a neuroprogressive element, meaning there may be damage to the brain if left untreated over time. And there's even an association potentially with later onset of dementia with bipolar.
On average, it takes upwards of a decade or more to get the right diagnosis.
That's right.
So if you can imagine living with something and not knowing that that's what it was for that many years can be very difficult. And I agree with you, Andy, that bipolar disorder is a neurodevelopmental disorder in the broadest sense of the term, neurodevelopmental, because it starts very commonly in adolescence and young adulthood.
Right.
And when you have more episodes, the disorder progresses to the level where it can actually affect your gray matter volumes in your prefrontal cortex. Thankfully, there are ways to reverse that.
That's right.
Over time with medication. And particularly, there's some studies that suggest that lithium can even reverse that neurodegenerative process in the prefrontal cortex. So very important for us to identify the symptoms early. They're made based on a clinical exam rather than a brain MRI, but you can get a sense of what might be happening over time through pictures of the brain, for example. They're not used diagnostically, but they help us understand that bipolar disorder is a neurodevelopmental disorder that can progress with the more episodes, manic episodes that one has over their lifespan. And really, our goal in treatment then is to reduce the number of episodes.
That's right. Yeah, and the good news is that many of our effective medicines, you mentioned lithium, have been shown to be neuroprotective. Lithium may even reverse some of it and be neurogenerative, but many of our medicines are neuroprotective. And again, we've shown that these medicines are not only potentially neuroprotective, they also can decrease the consequences of the illness and perhaps head off some of the negative medical, neurological, and of course, psychosocial complications.
You bet. All right, here's another one for you. Can bipolar disorder cause hallucinations? Let's talk about some of these psychological consequences.
Very interesting. As a matter of fact, yes, and maybe more commonly than most people realize, especially in the manic phase of the illness, when people have a full-blown manic episode, which is typical of what we call bipolar 1 disorder, as opposed to bipolar 2, which has hypomanic but never full-blown manic episodes, you can see psychotic symptoms, including hallucinations. Also, at the other pole of the disorder, when people get severely depressed, it is possible to have psychotic depression and have hallucinations. In some studies, what's been shown is that more patients with bipolar have psychotic symptoms than healthcare providers realize because we don't ask about it. We don't associate that with bipolar. And so some studies have suggested a fairly high incidence, perhaps as high as 60% of people when they're manic actually have psychotic symptoms. And fortunately, the treatments we use for bipolar, especially bipolar 1, often include atypical antipsychotics, which is a terrible term because they're more than just antipsychotics. They're mood stabilizers and they can have antidepressant properties. So they're mood disorder drugs. But they also have the benefit of treating the psychotic symptoms.
Like hallucinations, that's right, where there's a perceptual disturbance and you don't, you're seeing things that other people don't see or hearing things that other people don't hear. One thing that I would like to just add to that very important commentary on hallucinations Bipolar disorder can have highs and lows. Some people, when they're experiencing highs and can't sleep, might find themselves engaging in recreational drug use to potentially get them to sleep at night, in which case some recreational drugs might be, for example, associated with the development of psychotic symptoms. And I'm thinking of marijuana.
Absolutely.
And so then it becomes an even more complicated story to disentangle whether or not someone is having hallucinations because of the marijuana, someone is having hallucinations because of the primary bipolar disorder, chicken and the egg. These are all so complicated that it becomes very important to have an outside perspective, a healthcare professional, really tease some of these issues out based on a good history.
Good evaluation, clinical evaluation, yeah.
All right, so let's do the last one.
Okay.
Can bipolar disorder be treated with medication?
Oh, I'm so glad. Great question. Because the answer is a resounding and strong yes. Bipolar disorder, I like to say, is associated with a normal life if treated appropriately. This is not a death sentence. We have, as I mentioned earlier, many newer effective medications to treat bipolar disorder, not only evidence-based that have proven they can be effective, but even with FDA approvals, which is very important. So this is a condition I like to say like type 1 diabetes. With diabetes, I'm going to give insulin, but I'm not just going to give insulin and let you eat all the chocolate cake you want. I'm going to talk to you about exercise, diet, lifestyle. Well, same thing with bipolar, but medication is the foundation of treatment.
You bet. It's so interesting that there are a number of psychiatric conditions that actually could very well benefit from psychotherapies, talk therapy, ways to talk through the issues, symptoms that might emerge. I will say that bipolar disorder, in my humble opinion, is one of those conditions that certainly would benefit from talk therapy, but talk therapy alone will not address the underlying disorder and the symptoms and the impact that those symptoms have on your development, your functioning, and your overall well-being. So, while we would love to have people engage in talk therapy, and people with bipolar disorder certainly do benefit from talk therapy, it is not one of those things that you can just manage on just therapy alone. Medications are a central part of the treatment for bipolar disorder and need to be effectively integrated actually with psychotherapy because psychotherapy helps promote people to take their medications on time, helps them develop schedules so that they remember to take them because of the cognitive potential negative effects of recurrent episodes over time. We talked about how it's neurodegenerative can be when it's not treated. And so this is one of the aspects, as Andy was describing before, where medications are important not just for the treatment of acute symptoms, but potentially preventing future episodes. So we have to be able to appreciate that medications aren't just functioning to tamp down symptoms while someone is experiencing an episode, but really preventing the next episode and the episode after that so that we can slow or potentially reverse the progression of this disorder.
Yeah, we call that maintenance treatment, and I agree. Relapses or mood episodes are to be avoided if possible at all costs. And as Manpreet said, in addition to medication, various forms of counseling and psychotherapy are critically important and can help with learning healthy adaptive coping mechanisms, for instance, and strategies to manage your illness and to have better relationships with others, which is so important. Now, one other thing I guess that we want to talk about is a lot of times people like to use supplements and herbals and over-the-counter, and that's fine, but those alone have never been proven to be completely effective. There was some evidence for a while about fish oil potentially helping, and it may help, but it's certainly, to me, not a foundational mainstay treatment for this illness.
Yeah, some of those dietary and other supplements, nutritional supplements, get a bad rap in some ways because they haven't been systematically evaluated compared to placebo, for example, the way we rigorously test our medications. And in some ways, we really do need those kinds of data to help inform whether those treatments are helpful. One of the other things that we have to be mindful of is that we don't want to do harm unnecessarily by giving people things that potentially could worsen worsen their trajectories or perhaps even stimulate or cause a manic episode.
Oh, right. Well said, because there are many over-the-counter supplements that include stimulants, but it's not obvious that they're stimulants. There's a whole category called alkaloids, which are all relatives of stimulants. Some of them may include caffeine. That's obviously a stimulant. You don't want to use too much of that. But there's things like guarana seed, which is essentially caffeine, and then various other ingredients that, when you look them up, are in the alkaloid family. They're actually chemically related to cocaine.
Oh, geez.
And so obviously those would not be good in someone who's vulnerable to getting overstimulated or manic.
Yeah, you raise a good point about caffeine, and power drinks are increasingly on the market that people like to use to keep that up. For people who are living with bipolar disorder, sometimes they miss their manic episodes and so want to have a little bit of a kick and maybe do their own little chemistry, if you will.
Sure.
These are things that I think are really important to discuss with a healthcare professional, because in the grand scheme of things, you won't be able to achieve the kind of balance that you really want in your quality of life without input. And it's not to say that, these are things that can be done without the guidance or supervision of a physician. It's more that with the guidance and supervision of a physician, a healthcare professional, you have the opportunity to really get some outside perspectives and get some data to support why it's important to take one approach over another.
Listen, we're not saying caffeine is all bad. It's a matter of moderation, I would say.
Like everything,
like
right?
Everything else, all things in moderation, including moderation, as they say.
Yeah. So thank you for doing this with me, Andy.
You
I
bet.
really enjoyed auto-completing with you. Yes. And I look forward to hearing more questions from our audience and our colleagues in the ether, in Google space.
Google land.
Yeah.
Thanks.